My name is Anne McLaren, Senior Program Manager at the newly amalgamated organization that brings together the Canadian Patient Safety Institute and the Canadian Foundation for Healthcare Improvement. I'd like to welcome you on behalf of our technical host, Gina Peck, and co-host, Jerry Hansen, Executive Director of IPAC Canada. On behalf of us, I would like to begin by acknowledging that we are hosting this webinar on the traditional territory of Canada's Indigenous people. We respect the history, languages, and cultures of all First People of Canada, whose presence continues to enrich our vibrant communities. CPSI and CFHI respects that the First Nation treaties were made on these territories and acknowledges the harm and mistakes of the past. And we dedicate ourselves to collaborate in partnership with First Nations, Métis, and Inuit people in the spirit of reconciliation. Please write any questions you have in the Q&A box on your screen or chat them directly to myself, Anne McLaren. They will be compiled and provided to our speakers at the appropriate time. If you happen to run into any technical difficulties, please connect with us in the chat box, and Gina and I would be happy to assist you. If you miss any part of this webinar or you want to share your learnings with others in your team or organization, please know that it's being recorded and will be available on our website within the next week. You should also notice to the right of your screen, there is a live poll running. We invite you to take a moment during the next part of the webinar to answer the survey questions. Your responses will help us assess COVID-19 surveillance practices in Canada. Following the webinar, there will also be a quick evaluation survey that will appear on your screen. We ask that you take a minute to answer this survey, as it will help us plan and improve future webinars. At this time, I'd like to turn things over to our Vice President of Programs and Systems Transformation, Mary Ann Darpino, for some welcoming remarks.
Thank you, Anne, and hello, everyone. I'm delighted to welcome you all to this webinar, and we're thrilled that so many of you are tuning in from across the country and some international folks on the line as well to learn more about the COVID-19 Nosocomial surveillance program. As Anne mentioned, the Canadian Patient Safety Institute prides itself in working hand in glove with the field on topical and emerging issues to increase awareness with the goal of inspiring change and improving patient safety. One of the campaigns which many of you continue to support is Stop Clean Your Hands Day, which will take place this year, May the 5th. The campaign is in conjunction with the World Health Organization's Save Lives, Clean Your Hands campaign. And I know I'm singing to the choir when I say that cleaning your hands is one of the best ways to avoid the spread of infections. Over the last 19 years, CPSI has used learnings from the field to influence policy through many levers, and some of those include education, regulations, standards. We also work with patients, partners, and our stakeholders, including governments, healthcare organizations, leaders, and providers. We have been the only national organization dedicated to reducing preventable harm and improving the safety of the healthcare system. However, to positively change the healthcare system is not as simple as it seems. Levels of harm remain amazingly high. To do this, we must focus on fostering grassroots initiatives and strategic relationships at the provincial, territorial, national, and international levels to make patient safety and quality a system priority across all levels of the healthcare system and all jurisdictions in Canada. So we need to place emphasis on capability building by leading the development of innovative products and services and encouraging dissemination and uptake. And so to that end, we have joined forces with another pan-Canadian organization. So together with the Canadian Foundation for Healthcare Improvement, we have a shared commitment to create a single quality and safety organization with an expanded capacity to improve healthcare with and for everyone in Canada. In 2019, our organizations recognized the tremendous opportunity through amalgamation to achieve safer, higher quality, more efficient, coordinated, and patient-partnered healthcare. So we're excited about the opportunity to create a robust pan-Canadian quality and patient safety improvement organization that expands our capacity to be a valued partner in shaping the future of healthcare in Canada. So in 2020, CFHI and CPSI boards of directors and members voted unanimously to amalgamate the two Canadian healthcare organizations. So we are now officially and legally amalgamated and are in the process of building our new organization, which will happen in March 2021 as we announce our new name and brand to the public. I also did want to take a moment to acknowledge all of the healthcare providers and members of their associated teams and send a heartfelt thank you on behalf of CPSI and CFHI for your courage, compassion, and commitment to serving all of your patients each and every day. Thank you for making care safer. It's through your caring actions that lives are saved. So thank you. And without any further ado, I will pass things over to Jerry. Thank you.
Thank you so much, Marianne. Although IPAC Canada collaborations with CPSI began in 2006, our most important role to date has been in the combined efforts to advance HAI surveillance in Canada. As a result of the 2014 National Action Plan, a national committee co-chaired by IPAC Canada and AMI Canada met to discuss the pan-Canadian adoption of case definitions and the creation of a surveillance platform to collect, analyze, and report HAI data. That committee promoted pan-Canadian acceptance of CNISP acute care case definitions. At the same time, the IPAC Canada Surveillance and Applied Epi Interest Group and the Long-Term Care Interest Group collaborated on the updating of long-term care case definitions. Eventually, a cooperative of several organizational stakeholders called the Discovery Day Group and named after the purpose of its first meeting, met to discuss the need for HAI surveillance through an infection control lens. IPAC Canada advocacy has focused on bringing federal awareness to the urgent need for such a surveillance system and the ability to include long-term care and community settings in this data collection. Most recently, a Pan-Canadian Advisory Committee co-chaired by IPAC Canada and CPSI-CFHI has been appointed to work towards acceptance of these acute care and long-term care case definitions and to explore and test strategies towards the Pan-Canadian collection and reporting of HAI data. It has been a long road, but as you will see in the presentations, there has been success. Today, we will be hearing from staff and members of CNISP, where they will provide data and details of the COVID-19 surveillance program. Please join me in welcoming Robin Mitchell, Senior Epidemiologist at the Public Health Agency of Canada, Blanda Chow, an epidemiologist with Alberta Health Services Infection Prevention and Control Program, Jennifer Ellison, also an epidemiologist with the Alberta Health Services Infection Prevention and Control Program, and Elaine Hunter-Gutierrez, the Interim Coordinator of Infection Prevention and Control at London Health Centre. Thanks so much for joining us today, and Robin, please take it away.
Okay, thank you very much for the warm welcome, Jerry. And I think I'll just wait for the slides to pop up and then get started. Okay, there we go. So thank you very much. It's great to be here and to have the opportunity to present some of our findings from CNISP. So just a brief overview, I guess, of what the objectives of today's webinar. So we'll be providing an overview of the CNISP COVID-19 surveillance protocol and some key definitions. I will also be presenting some key findings to date from our surveillance, and then you'll have the opportunity to hear from some of our participating hospitals and their experiences and lessons learned from participating in CNISP COVID surveillance, and then there'll be a chance at the end for some questions. So a bit of a background regarding the Canadian Nosocomial surveillance program. CNISP is a collaborative effort between the Public Health Agency of Canada, the Association of Medical Microbiology and Infectious Disease Canada, and Sentinel hospitals across the country. And the Public Health Agency has supported CNISP over the past 24 years to conduct national surveillance of healthcare-associated infections. And CNISP, we currently includes 11 surveillance systems, and we also conduct periodic point prevalence surveys. We conducted surveillance of viral respiratory infections from 2006 to 2013. And at our annual meeting in the fall of 2019, we decided to reestablish this surveillance, which was quite timely because when the pandemic arrived, surveillance was expanded to include COVID in March of 2020. And so this is a map showing the location of all of our CNISP hospitals. So we have 78 acute care hospitals in our network across 10 provinces and 1 territory. As well, we have 11 standalone pediatric hospitals. And essentially, one of the main objectives of CNISP COVID-19 surveillance is to describe the inpatient population that is infected with COVID-19. And by doing so, we're able to identify any emerging trends among this hospitalized population, as well as which will provide information to inform infection prevention and control strategies, as well as to help prioritize healthcare resources. So some of our data has been used to support the NACI recommendations for vaccine prioritization. Data is used for modeling here at the agency, as well as for internal IPC reporting and benchmarking at the hospital level. And one of the long-term objectives that we do have is to look and measure the impact that COVID has had on antimicrobial resistance and healthcare-associated infections. So our surveillance is broken down into 2 main components. The traditional collection on the left is the first. So kind of traditionally, we collect detailed questionnaires on patients of all ages who are hospitalized with lab-confirmed COVID. And it's a pretty lengthy patient questionnaire. I'm sure many of our hospitals would attest to that. So we collect information on demographics, clinical characteristics, acquisition and exposures, treatments, interventions, and outcomes. And so currently we have 55 CNISP hospitals who submit data. And currently, as time's going on, we're seeing more hospitals that are able to join due to resources and report retrospectively. So that's great to see. And with this information, we produce a report monthly just describing our findings. The second component, and this is really similar to actually what CNISP did during H1N1, is we collect weekly aggregate data to monitor trends over time. So we collect the number of new patients with lab-confirmed COVID. We also collect data on the number of ICU admissions, those receiving mechanical ventilation, those on ECMO, and those who died. And we stratify that by the 5 age groups listed there, and we combine this to provide a weekly trend report. And so for this component, we have 151 hospitals. So those are our CNISP hospitals plus all Alberta acute care hospitals. Now, our data for this surveillance are submitted year-round for both components, and trained infection control professionals, they conduct the chart reviews of eligible patients, and then that information is submitted in the Canadian Network for Public Health Intelligence, which is a secure online platform. And then we produce automated reports in our Markdown, which are disseminated to our CNISP hospitals and are used internally here at the agency. So now I'm just going to highlight just a few of the definitions, and these are all available in our protocol. So the first definition is how we define a COVID case. And so the 2 inclusion criteria are that any patient who is identified with a lab-confirmed positive COVID test while they're admitted. And the second inclusion criteria is any patient is identified with COVID in the 14 days prior to being admitted to a CNISP hospital. And as with many of our protocols, there's a lot of clinical judgment that's allowed, especially given COVID and things have been changing very rapidly. And so, as with all of our other surveillance protocols, we're also quite interested to look at whether cases were where they were acquired. And so this is the definition that we've come to, the working group has developed regarding, the first one here is healthcare associated acquired in your facility. And so that is that symptom onset has to be 7 days or greater after admission to the reporting hospital. And then again, using your best clinical judgment, if there's patients who have symptom onset that's less than 7 days, but they have a known epi-link to a positive case, then that would be included as well. As well, we also collect information for patients who potentially acquire their infection in another healthcare setting. So any patient who is identified with COVID not acquired at your facility, but that is believed, based on the data available in the patient chart, to be associated with another healthcare exposure. So either transferred from another healthcare facility. Obviously, we're seeing a lot of people coming in from long-term care home as well. And then one of our other main categories is community associated. So they didn't have exposure to healthcare that would have resulted in their infection. And we also collect data on whether the patient was admitted from a long-term care or retirement home. And we've defined that, which was a bit challenging to come up with this definition, to be honest, when we're looking across different provinces. But it's defined as a private or public care home, a residential assisted living building, or a nursing home with varying levels of care for older persons. And we did exclude group homes for people with developmental disabilities, mental health, or addiction issues. And, the purpose of that, we really wanted to focus on the elderly population and facilities versus all those in a congregate living setting. And so that's the direction that we took for this surveillance. As well, we also collect information on healthcare personnel, which is defined as any individual who works in a healthcare setting. So this includes whether they work in acute or long-term care and then end up in hospital, meeting our definition. And then we further look at whether those healthcare personnel who are hospitalized, if they provided direct care, and the definition is listed here. So it's in-person patient care with or without the use of PPE. So those are just some of our key definitions, and they're all also available in our protocol if you are interested. But kind of on that note, I'm just going to go over two surveillance case scenarios. So kind of whether to include a patient or not, because it has been a bit of a challenge, as we know, as things with COVID evolve. So I'll go through the scenario, and you can kind of think about it, and then we'll present the answer that we would come up with based on our definition. So the first scenario is if a patient tested positive on admission for COVID, was hospitalized from October 14th to the 28th, and was later readmitted, COVID positive again on November 30th. Would this patient be considered, the readmission be considered a new case? Because we do see this happen quite frequently. So I'll just let you kind of mull that over for a few seconds. Oh, and I think there's a poll that's popped up there as well. Okay. And so the answer to this question is no, we wouldn't include this patient, and this is the definitions that we have, the criteria in our protocol. And so if the patient is readmitted within 30 days of the positive test, we collect all of the data on the same form. In this situation, if the patient is readmitted between 31 and 89 days after their positive test, we're not capturing that. But something that is of interest is if the patient is readmitted and is positive 3 months after their initial admission, we are quite interested to capture that information. And so you would create a new form, and it would become kind of a new case. And then we ask you indicate, we have a unique identifier that you provide that so that we can link all of that patient information. The second scenario is a female test positive on November 2nd in the community, and then she is admitted from November 20th to the 8th for pregnancy. She swabbed twice again on November 27th and has both a positive and a negative result. Then on December 2nd, she is tested again and has another positive result. And so the question, we see this a lot, should this patient be included in surveillance when the patient is flipping back and forth between positive and negative? So I'll give you just a second there to think about that, if we should include this patient based on the information provided. And so the answer to this is also no, and the main reason being that the patient did not meet our very first criteria. So they were admitted greater than 14 days after their first positive test. As well, they had no symptoms on admission. And as was also added was that IPC also confirmed that her subsequent positive tests were really the result of prolonged viral shedding and not active infection. So that's just kind of an example of some of the scenarios that we run into. And so before I jump into presenting some of the data, I'll just present some of the limitations up front to help with the interpretation. Okay, so one of the main limitations currently is our data completeness, and this will definitely improve with time. But this graph here shows on the number of cases reported over time, and the light blue bars, those are the number of cases that are reported as per our weekly reporting. So the aggregate number of cases, and that's really the gold standard for us to know how many cases are being hospitalized. And then the blue bars are the number of patient questionnaires we've received. And so you can see kind of in the first wave, the completeness is quite good. We've received most of the patient questionnaires, but moving into the fall and winter, there's a bit of an issue with completeness. Which is quite understandable given the burden that all of these hospitals have been under responding to COVID. So this will definitely improve as time goes on. But again, important to remember when we're interpreting the data that some of the data, during this time is preliminary and potentially subject to change. A few other limitations. So the data collected were really limited, obviously, as I mentioned, to the information that's available in patient charts. And so, for example, ethnicity is a variable that we do not collect. And we've had many discussions about this as it's a valuable piece of information to collect, but it's just information that's not routinely collected or captured in a standardized way, especially across the country. And we ran into the same situation during H1N1 that it just wasn't readily available. So again, our information is based on what's in the patient chart. And our ICPs and EPIs, answer the questions to the best of their ability. We do have limited representativeness of the larger acute care hospitals in British Columbia, and so we're working to improve that. 30-day outcome, that's what we collect for all of our surveillance projects. And so it is a standardized metric, and it does allow for timely reporting because we're not following the patient until discharge, but this may underestimate some outcomes that occur past 30 days. As well, hypertension was included with heart disease. We have updated our protocol. So starting in December, we are now stratifying that and able to report on hypertension separately as it's been identified as a risk factor. We don't collect information on code status or do not resuscitate orders, and I'll speak to that near the end when we look at some of our outcomes. And we're not always able to determine the source of infection for long-term care or retirement home patients who come in from those areas. So now I'll jump into some of our key findings from our weekly data. And this first graph is the weekly incidence rates of patients that are hospitalized with COVID-19 per 1,000 patient admissions. And so this figure represents just over 12,000 cases that are reported from 151 hospitals from the beginning of March or the middle of March to pretty much the end of January. And you can see here our first wave, and then we have our second wave, which does actually appear to be on the decline. And, so it's important to keep in mind that this is the incidence of cases, so the number of new hospitalizations, and it is very good to see those numbers decreasing, but I think it's also important to keep in mind that the burden or the prevalence of COVID in hospitals is still quite significant given the longer length of stay that COVID patients have. This figure shows the number of patients hospitalized with COVID by age group. And so at the beginning in March, we collected data just for 3 age groups, so pediatrics less than 18, those 18 to 59, and then 60 plus. And then as the pandemic kind of evolved, we recognized that it would be important to look at, some of our younger adults and the very elderly. And so at the end of August, we expanded to these 5 age groups. So that's why the data doesn't go back to the beginning of March. And as you can see here, the number of hospitalizations is highest among those 60 to 79, followed by those over 80. And we're starting to see a decline. I would definitely interpret this last data point with some degree of caution because there is a slight reporting lag involved. So sometimes the numbers are updated. This figure shows that the percent of patients receiving mechanical ventilation was significantly higher in March and April compared to May onwards. And so this is just an interesting trend that we found from some of our weekly data, and it really reflects, the change in treatment that we observe as our knowledge of COVID has expanded. This figure is the number of patients hospitalized with COVID who died. So looking at the beginning of March in our first wave, and then we peaked, near the end of December, and thankfully we're starting to see the number of deaths decrease. Again, interpreting that last week there with caution. So we also collect information on where the patient likely acquired their infection, and this is based on the definitions that I just previously presented. So you can see here, this is data from middle of March till the end of January. I've kind of highlighted the first month here because there is a substantial amount of data that is missing or unknown. So that's important to keep in mind. But I think it's pretty clear that the majority of patients acquired their infection in the community, so the gray bar. And that we do see in the orange bar here pretty limited nosocomial acquisition, so healthcare associated. The proportion of cases quite low at the beginning of the pandemic, and then we do see an increase in the fall and winter, and that increase has been pretty sustained and consistent. The blue bar representing that other healthcare exposure, and based on our patient level data, we know that the majority of these are patients from long-term care. And recently, as of the end of November, we also have started collecting data on the number of hospitals reporting a new COVID-19 outbreak. And so you can see that distribution here, ranging from about 8 hospitals experiencing an outbreak to 20. A limitation of this information, though, is that if a hospital has more than 1 outbreak, that's not captured. So it's really the number of hospitals that are reporting an outbreak. And that's kind of the findings for our weekly data. And moving more into our patient level detailed information that we collect. So as of January 8th, we've received almost 3,000 patient questionnaires from 55 hospitals. And our data shows that patients hospitalized with COVID are, for the most part, older adults. So this is not overly, surprising. The median age is 69 years, just over half are male. We are seeing few pediatric hospitalizations, and the majority, 86%, have at least one underlying medical condition. And this figure here shows the percent of patients with underlying medical conditions stratified by age group. The top conditions being heart disease. As I mentioned, this currently includes hypertension, as we're not able to separate that out just yet, diabetes, lung disease, and then the dementia and Alzheimer's really reflected by our very elderly patients. So you can see a breakdown in some of those age groups there among some of our key medical conditions that we see. And also we know that about 9% of patients hospitalized with COVID-19 who are between the ages of 16 to 65 were healthcare personnel. And where data are available, you can see here we're missing a fair amount of data on this. 75% provided direct care to COVID-19 patients. And the reason we're missing, I think, a lot of this information is, this type of information may not be readily available in patient charts. And I think it's also important to recognize that, it's really beyond the scope of our surveillance to determine whether a healthcare provider who was hospitalized acquired their infection while occupationally or out in the community. And so that's something that definitely requires further study. We also compared healthcare personnel who were hospitalized to all other patients who were not healthcare personnel who were hospitalized. We see that ages are quite similar, so 52 and 53. We see that healthcare personnel has a larger proportion of patients that were female, which makes sense with that type of profession, and we see that also in the literature. We also see that healthcare personnel had fewer comorbidities. But is of interest is to see that hospitalized healthcare personnel, they were similar with respect to non-healthcare personnel with respect to severe outcomes. And I think there was also a recent article that I came across, a recent publication describing healthcare worker data from North America, which also reported similar findings with respect to having similar outcomes between these two groups. We also know that unfortunately a third of patients who are hospitalized with COVID were admitted from a long-term care or retirement home. And in our bivariable analysis, we found that 30-day all-cause mortality among patients hospitalized or patients admitted from long-term care or retirement homes was significantly higher than those not admitted from a long-term care home. So really highlighting the impact, the negative impact of the pandemic on this vulnerable population. And this figure is a heat map which shows symptoms reported by patients hospitalized with COVID. The most common symptoms at the top being cough, fever, and shortness of breath. And we have, again, stratified these data by age group. And you can see that the darker areas indicate a higher proportion. So, for example, we see some of our younger patients reporting symptoms such as runny nose or sore throat, so nausea, vomiting, and fever are very common among that population. So that just shows kind of the breakdown by age. And this figure shows the median length of stay of patients hospitalized with COVID. Now, I've included a note here, as I mentioned, CNISP collects 30-day outcomes, so we're not following people till discharge. So this will result in a shorter length of stay, but these information are, quite useful to look at over time. And is what we are seeing is a shorter length of time, a shorter length of stay really in the summer. So you can see in the spring, it ranged from about 7 to 8 days, and then we saw a dip in the summer, and then it appears to have increased in the fall, acknowledging that we have a bit of a reporting lag here, and so that will be filled in as we have more data. Length of stay also appears to increase with age, so we see our younger population having a shorter length of stay. So this decrease in the summer, we hypothesize, is due to the fact that a younger population was hospitalized during the summer. This figure shows treatment over time. So here in the blue, we see the proportion of patients who received at least one antimicrobial. So at the beginning of the pandemic, approximately 70% of patients were receiving an antimicrobial, and then that decreased in the summer and has steadily increased. And overall, 64% of all of our hospitalized patients received an antimicrobial. Then we have the orange line here, which is the proportion of antivirals that were received. Again, a bit higher at the beginning of the pandemic. As information evolved, we saw that decrease. And overall, 8% of our population has received an antiviral over the course of the pandemic. And the yellow line is really interesting because this is the proportion received of steroids. So again, similar to that mechanical ventilation piece I showed you, our data is showing how a true reflection of what's happening and how the use of steroids has increased over time as our information and knowledge evolves about how to treat patients with COVID. And overall, approximately 25% of our population has received an antimicrobial. This slide shows data for some key interventions among patients hospitalized with COVID. So we know that our data shows that approximately 24% of patients were admitted to the ICU, primarily among those 60 to 79 and 40 to 59 years. We do see that few elderly patients, so those 80 plus, were admitted to ICU, even though they have a high mortality. And we speculate that this is likely due to advanced planning directives. And as I mentioned previously, we don't collect that information, but that's our hypotheses. And then mechanical ventilation, 14% of patients receive mechanical ventilation with a similar age breakdown to those in ICU, which which makes sense. 5%, just under 5% of patients received CPAP BiPAP, and 2% required dialysis as a result of their infection, and approximately 1% of patients were put on ECMO. So this is the final data slide, and it's looking at severe outcomes among our hospitalized population. And as I mentioned earlier, CNISP collected data on lab-confirmed influenza from 2006 to 2011. So we thought it would be of interest to kind of compare some of these severe outcomes and between the two infections. And what we see here that, the proportion admitted to ICU was quite similar between the two populations. As I mentioned, 24% of patients with COVID-19 were admitted to ICU. We do see a higher proportion of patients who received mechanical ventilation among those with lab-confirmed influenza. But what is really interesting and I think reflective of what hospitals are seeing is that 30-day all-cause mortality is 2.5 times higher among patients with COVID compared to flu. And then the attributed mortality is actually 3 times higher among patients hospitalized with COVID compared to flu. So our data is really showing that there is a substantial proportion of patients hospitalized with COVID that have received critical interventions and have had poor outcomes. We've also conducted some multivariable logistic regression, and one of the key things which aligns with what we're seeing in the literature is the strongest predictor of mortality really being age, in addition to a few other factors. And so that is it for a quick review of the data. Hopefully it was of interest and of value, but I think now we'll shift over to review some lessons learned. And I think I'll pass it over first to Elaine from London Health Sciences just to share her experiences and lessons learned from doing COVID-19 surveillance.
Hi, can you hear me?
Yes.
All right. You can continue to be in charge of the slides if you wish, Robin.
Yes,
I won't take over. Okay. So lessons learned. So generally speaking, for London Health Sciences Centre, CNISP is just part of our everyday life. We've been doing it since the beginning of CNISP. So it's built into our workflow pretty easily. And actually, I've never worked here without it being already present in our department. So when the ask was to provide COVID data, we readily agreed and started working through the process. What it does and what we've learned by working with CNISP is it, especially in this aggregate data, is it provides infection control, an ability to have a data set for admissions and tracking of admissions, as well as tracking of admissions for critical care and ventilator data without the need to go through decision support to get that information. So we can definitely work with decision support to get overall aggregate data, but sometimes it takes a lot of work to be able to define it in the timeliness that we need. So we have been keeping track of this on our own, and I'm not to say that decision support wouldn't be able to provide that data, but it does provide us our own data set. So that is one thing. And also oftentimes as leadership, we get asked from other leadership, hey, how many admissions do we have this week? Because that ultimately comes down to planning for the hospital, and infection control is oftentimes asked that information and expected to respond in a quick manner. So also, right now, because of COVID and the Wave 2 response, we have been provided redeployed staff to help with our COVID response. And oftentimes what we utilize them for is things related to the COVID questionnaires. So that is very helpful. So if there's information to be retrieved from the clinical chart, these redeployed staff are very helpful, especially when we have conflicting priorities with outbreak response and requiring ICPs to the infection control professionals to focus on outbreak response or other things within the hospital that is also equally important. And then finally, what we found is that participating in CNISP allows us to do comparative analysis of our hospital data versus other Canadian hospitals. So like to like, we're an acute care facility a teaching acute care facility. So we'd like to see how everybody else is doing that is also in our cohort. So that is also very helpful. Robin?
Great, thanks, Elaine. Okay, now I will just pass it on to Jennifer and Blanda from Alberta Health Services.
Thanks, Robin. So while people on the call might not be aware of this, but Alberta has a system set up to be able to capture data at all of the acute care facilities within the province. We have a provincial surveillance system, and we've been working with CNISP right since the beginning to submit data from all of our Calgary acute care sites, as well as a couple sites up in Edmonton. But what we were able to do when COVID started was work with CNISP to figure out what that protocol would look like. We worked collaboratively to understand and create these standardized case definitions. And then we provided data from all of our acute care hospitals in the province to CNISP. And so we were able to electronically extract that data weekly, and it's actually a very smooth system to be able to report that. So we're really grateful that we're able to provide that data to CNISP for those weekly submissions. Having those standardized case definitions right from the beginning really helps us as we move forward with these tricky cases. And Robin was able to show you some of those examples, but there is a multitude of more tricky cases. And so knowing how you've answered it once helps you to keep answering it the same way going forward, which helps with comparing data. And so really grateful to have those standardized case definitions. And then I'm going to pass it off to Blanda to talk about those patient questionnaires. Thanks.
So for the patient questionnaires, we found it easier to fill out if you have access to an electronic patient charting. However, even though we were using electronic charting to find the information, we found that some of the items were more difficult to identify in the chart, so such as antibiotic exposure and also symptom start date. And on average, we felt it took about 10 to 15 minutes to fill out one patient questionnaire. So when the second wave of the pandemic hit in December, we were quite overwhelmed with the cases to review because we had over 500 cases from 4 hospitals in December. And with the increase in number of cases and with competing priorities, we weren't able to submit these patient questionnaires at that time. But we will be taking time in the future to capture these data for the CNISP. Now I'll just pass it back on to Robin.
Great, thank you both. Lots of great insight there from both sites. And then I'll just quickly mention a few lessons that we've learned from a national perspective from doing our COVID surveillance. And so, there's a challenge around the changing epidemiology. I know it's a challenge for everybody in kind of every realm, but it's, we find it a bit of a challenge from a surveillance perspective because we really strive for standardization and things have just never stayed the same. And so I think this again highlights the importance of having clear surveillance objectives and definitions to really stick by. And then if you need to change them, thinking about the impact that will have on your data and interpretation. We also found it extremely useful to have training with those collecting data and submitting and to really work with them to come up with definitions. And so this is really key to the quality of the data so that everyone is interpreting all of our questions. This is across the country and there's provincial differences and territorial differences. So that has been really key. I think CNISP may be considering, having a surveillance plan and tools for future pandemic planning so that we're not always, reinventing the wheel a lot of the time. But also recognizing that there has been such significant value in having this established network of acute care hospitals that we're really able to rapidly implement this COVID surveillance. Data started rolling in at the end of March, which was amazing. And they've been able to adapt along the way, which has been fantastic. And I think it's worked so well because we've had this system in place
for 25 years. And so the process was there for data collection and submission reporting. And so it was, I think really just a matter of resources. So that was a huge bonus. And so on that note, I would like to thank and acknowledge all of the ICPs and EPIs and all of those who are responsible for collecting and reporting data at the reporting hospitals. Our CNISP working group, we're extremely grateful as always for their contribution and their expertise, as well as the great staff here at the agency. Our protocol is posted on the CPSI website if you're interested, and our email is here should you have any questions. Thank you.
Thank you so much, Robin, Blanda, Jennifer, and Elaine for that very informative presentation. Really what your presentation has done for me is just provided some insights as to how detailed and complex HAI surveillance is. And I'm sure our audience has some questions for you as well. So please remember that you can write your questions in the Q&A box on your screen or chat them directly to me, Anne McLaren, or Jerry Hudson. So while we wait for your questions to come in, I'm going to turn the mic over to Jerry to get the conversation started. Jerry?
Thank you very much, Anne. We do have some questions submitted, and I'll start with a question for Robin. Robin, what is the percentage of patients hospitalized with COVID-19 who are co-infected with an ARO?
So based on the data that we've received thus far and on our patient questionnaire COVID data, it's really very few. So, less than around 1%, I would say. We've captured data on MRSA, VRE, or CDI infections. Recently, I think in the fall, we expanded to look at some other infections. And something I think that will also help us kind of answer that question as time goes on is, for all of our other surveillance protocols or routine ones, we have also added questions if that patient was COVID positive, if that's available in the chart. So we'll be able to link all of that information in the future. So I think right now we know not very many based on our data, but I think that'll definitely come out as time goes on.
Thank you, Robin. Another question for Robin. Does antimicrobial refer to antibacterial, antifungal, and antiviral? Is there a specific estimate for the proportion of patients receiving antibacterial agents?
Yes. So the graph that I showed regarding treatments, that is just antimicrobials. It does not include antifungals, and then antivirals is separate. So we do know that CNISP data shows about 64% of patients over the pandemic, the course of the pandemic, have received an antimicrobial over that time frame. And so, CNISP also collects antimicrobial use separately than COVID. So we will, that's something else we'll be looking at in the future to see the impact of COVID on the data coming in on antimicrobial use.
Thank you, Robin. I see that Kim Newdor has joined the call today. Kim is a member of Patients for Patient Safety Canada and has been a key collaborator in our efforts to advance HAI surveillance. Kim has a question. What are the recommended screening practices on admission to a long-term care facility or a hospital? I know that this will depend on provincial guidance, but I'm wondering if I can direct this question to Elaine to talk about the Ontario situation.
Hi, sure. I can talk about guidance in Ontario, and again, my frame of reference is Ontario, and the guidance has changed over time. So I'm not going to review the 10 to 11 page document that the province has outlined on their website, but generally speaking, in Ontario, there is guidance for symptomatic individuals as well as asymptomatic individuals. And the question was more specific to long-term care. There is a directive number 3 related to long-term care, and any patient that, to summarize, any patient that is going to be transferred to long-term care from another facility has to have a negative swab before they're transferred. There is some other asymptomatic guidance related to transfers from facility to facility, specifically around admission screening from facility to facility, separate from the long-term care. And so also there's guidance on transfers to residential facilities such as group homes or other congregate settings. So all of it's outlined in the provincial guidance, but generally speaking on prior to admission, most require a negative COVID swab.
Thank you, Elaine. A question for Robin regarding the graph where antimicrobials, antivirals, and steroids were used as treatment. Were patients who use an inhaler for asthma included? For instance, was it taken into account if they received an antimicrobial as a treatment?
I don't believe so. No. I can confirm that, but I don't think so. A question arrived separately. What are some of the intended consequences hospitals are experiencing due to the increase in patients hospitalized with COVID? For example, cancellation of surgeries, healthcare worker burnout, etc. And I'm wondering if I could direct that to Jennifer to give her response from her experience.
Sorry, I'm just trying to get everything unmuted. I think that when it comes to seeing increased COVID-19 patients hospitalized in our facilities, it definitely, I think we see an increase in outbreaks. The more patients we see coming into our facilities, that definitely the burnout piece from staff having to deal with that. From an infection control perspective, it's that constant vigilance and monitoring. Is your unit now on watch or on outbreak? Extra stress and having to keep an eye on those patients that are admitted and looking at the various precautions that are being implemented to prevent that transmission. Burnout for sure. I think when we see that increase in our community prevalence, it spills over into the hospital setting and puts strain on the hospital for all that are working there and all involved in it. And welcome any other comments from anyone else on the call.
I wanted also from Alberta, but what's your experience and your thoughts on the consequences to hospitals?
Pardon, what was the question, Jerry?
Sure. What are some of the intended consequences hospitals are experiencing due to the increase in patients hospitalized with COVID? For instance, cancellation of surgeries, burnout, etc.
Yeah, for sure. Our hospitals, we've definitely seen decreases in surgeries, and also probably, I'm sure there is healthcare worker burnout.
Yeah, I just want to remind everybody that our IPAC Canada 2021 conference will have Dr. Linda Duxbury, whose topic will be on burnout and the mental health of healthcare workers. So we encourage you to join us for that presentation. Question for Robin. Do we have any data on antibiotic usage during the pandemic? Has the pandemic resulted in changes to antibiotic care, or antibiotic use, rather?
Yeah, and so I think this is similar to my previous answer. So we do know that approximately, 64% of patients hospitalized with COVID have received at least one antimicrobial. A bit of a shift among adults, that's 66%. And among our peds patients, that's much lower at 29%. And so that's the information that we received from our patient questionnaire data. And again, use also much higher in the ICU we're seeing, which, makes sense. And so, as I mentioned, CNISP does collect antimicrobial use as a separate surveillance project. And so we will be looking at how that data has changed and been impacted by the COVID. So that'll come a bit later once we receive all of that data.
So I'd just like to remind our attendees that you can put your questions into the Q&A box, or you can email myself or Anne directly. But please do put your questions in the box so they can be answered today. I have one last question also for Robin. How far away is Canada from each hospital and long-term care being able to measure and report healthcare-associated infections?
Well, I don't know. I mean, I can answer that perspective, or that question probably from a CNISP perspective. And the long-term care piece is an unknown for us right now. But for CNISP, we've been working on establishing a minimum data set surveillance for all of our key antimicrobial resistant organisms, so our AROs, CDI, MRSA, VRE, CBO, our SSIs, for all acute care hospitals to submit their HAI data. And so we're looking to expand that to all acute care facilities in Canada. So we're working on setting that up in SINFI and figuring out how exactly that will work. And so we've definitely been putting a lot of work into that. It's on a bit of a pause right now. But so I can't really confirm how far off we are from knowing that information, but I think plans are in the works to be able to answer some of those questions.
Thank you. So what are some of the indicators used to interpret other healthcare exposure in long-term care?
We don't, I'm not really sure if I could answer that question because CNISP, we don't conduct surveillance in long-term care homes. And so I don't know if anyone else on the call would have an answer for that. Our data just currently collects whether they were admitted from a long-term care home. And as you saw the definition, they could also fall under acquisition in another healthcare facility, which is also, subject to a bit of interpretation.
Jennifer, do you have a response to that question about what are the indicators used to interpret other healthcare exposure in long-term care?
I don't, Jerry, sorry.
So I want to remind attendees to please put your questions in the chat box or the Q&A box, and we'll get to them right away. Concerning the chart on the proportion of those with underlying medical conditions, does it reflect data among those who had nosocomial infections during admission, or was this baseline data prior to admission?
So this is all patients. So whether they acquired their infection while in the hospital or prior to in the community. And the information is what's available in the patient chart. So that's an underlying medical condition that they've come into the hospital with or has been diagnosed while they're in hospital. But it's among all patients.
We noticed the increase of steroids, the use of steroids. Did this result in better outcomes?
So that's a great question, and that is something that we're definitely going to be looking at. One of our next analyses, we'll be looking at some survival analysis. And so the steroids will be a big variable that we'll be including and looking at that for sure. So I don't know the answer to that based on our data.
Thank you so much, Robin. Thank you, Robin, and our presenters for your response to the questions. We appreciate them, and we appreciate the questions from the attendees. So, Anne, I'll turn it over back to you.
Thanks so much, Jerry. And I also want to extend our thanks again to our speakers, Robin, Elaine, Jennifer, and Blanda, for sharing their expertise and their time. So on behalf of me, Anne McLaren, and our technical host, Gina Peck, and the rest of the team here, I want to extend my sincere thanks to all of you for taking the time to attend. So just a reminder, please take a moment to respond to the poll that will appear on your screen when you exit the call. And if you want to continue the conversation, or if you have additional questions, please feel free to send us an email, and we'll forward your comments and questions on to our speakers. Also, as a reminder, we will be posting a recording of this webinar on the CPSI website within the next week or so. So join us online at patientsafetyinstitute.ca for additional resources. And here you'll find the surveillance definition protocols for both the long-term care and acute care. Have a wonderful day, everyone, and we look forward to seeing you again soon. Bye for now.
Thank you, everybody.